All right, we're diving straight into a relentless, rapid-fire clinical gauntlet today. No fluff, just absolutely high-yield, straight-to-the-point endocrine surgery knowledge. We're going to be testing your mastery of thyroid and parathyroid pathology, so let's jump right in and test your clinical precision. Question 1. Imagine you're evaluating a patient with a newly diagnosed thyroid malignancy. You need to know, what's the most common histological subtype of primary thyroid cancer you'll actually encounter clinically? And, crucially, what is its classic pattern of metastatic spread?
Okay, here are your options. Is it A, follicular thyroid carcinoma with hematogenous spread to bone? B, papillary thyroid carcinoma with lymphatic spread to regional nodes? C, medullary thyroid carcinoma with direct extension right into the trachea? Or D, anaplastic thyroid carcinoma with slow local invasion?
And the answer is B, papillary thyroid carcinoma. This is by far the most common thyroid malignancy, accounting for over 80 to 85% of all cases we see. It's characteristically indolent, meaning it's a slow grower, but here's the catch. It has a huge propensity for early lymphatic spread. It loves to jump to regional cervical lymph nodes. It usually hits the level 6 central compartment first and then moves to the lateral neck levels I through 4. But despite this high rate of nodal involvement, the overall 10-year survival rate is fantastic, exceeding 90 to 95%.
Moving right along to question 2. Let's say during a total thyroidectomy for a large multinodular goiter, the surgical team unexpectedly finds a distinct malignancy. On histopathology, the tumor cells show those classic orphan Annie eye nuclei. You know, those really large, optically clear, crowded nuclei? They also spot these concentric, lamellated, calcified structures. So what exactly are these calcified structures called? Your choices are A, Mallory bodies, B, Samama bodies, C, Schaumann bodies, or D, Councilman bodies.
The correct answer is B, sesamoma bodies. Look, whenever you see orphan Annie eye nuclear inclusions, nuclear grooves, and sesamoma bodies together, you are staring right at the pathognomonic histopathologic hallmarks of papillary thyroid carcinoma. These sesamoma bodies are essentially microscopic concentric laminated calcified structures. And what they actually represent is pretty fascinating. They're the infarcted, dying tips of the papillae within the tumor itself. On to question 3. A 42-year-old female undergoes a fine needle aspiration, or FNA, of a firm, 2-centimeter solitary cold thyroid nodule. The cytopathology report returns as follicular neoplasm, meaning Bethesda category 4. So why is a standard FNA biopsy completely unable to definitively differentiate a benign follicular adenoma from a malignant follicular thyroid carcinoma? The answer is B. Tissue architecture is required. You see, while the cytology from an FNA can easily spot follicular architectural patterns, it just can't tell you if it's a benign adenoma or a true carcinoma. Why? Because the absolute defining criteria for follicular thyroid carcinoma are either capsular invasion, where the tumor literally punches right through its own fibrous capsule, or vascular invasion, meaning tumor cells have breached blood vessels outside that capsule. An FNA is only pulling out isolated cells, right? It totally misses that intact capsule boundary. So you really need a formal surgical lobectomy or total thyroidectomy to get that definitive tissue architecture. Let's tackle questions 4 and 5 together. Consider a 35-year-old male with a family history of aggressive thyroid cancer. He has a germline activating mutation in the RET proto-oncogene. Because of this specific mutation, he is virtually guaranteed to develop medullary thyroid carcinoma. Now, this tumor uniquely originates from the neuroendocrine parafollicular C cells. Roughly 25% of these cases are hereditary, driven by this RET mutation, often as part of MEN2 syndromes. And since it arises from those C cells, the vital serum biomarkers we meticulously track after surgery to screen for recurrence are calcitonin and carcinoembryonic antigen, or CEA. If you see any rise in these markers, it's a huge red flag that the disease is back. Question 6. We have a 75-year-old female presenting with just a 2-week history of a rapidly expanding, massive neck mass. It's causing acute dysphagia, stridor, and she has new-onset right vocal cord paralysis. A core needle biopsy reveals highly atypical, pleomorphic spindle and giant cells with abundant mitosis. What's the diagnosis here, and what's the standard clinical prognosis? It's anaplastic thyroid carcinoma. Answer B. Look, this is an exceptionally aggressive, near-universally lethal tumor. It classically hits elderly patients and presents as a literal rock-hard neck mass that rapidly invades local structures. That's what causes the airway stridor. And the nerve invasion is what leads to that vocal cord paralysis.
The brutal reality is this tumor is considered stage 4 from the very moment of diagnosis. It's highly resistant to standard therapies, and sadly, it carries a median survival of only a few months.
Okay, let's group questions 7, 8, and 9 to see how this all builds. During any thyroidectomy, the vital nerves of the neck are at major risk. So how exactly do injuries to the external branch of the superior laryngeal nerve, the ESLN, and the recurrent laryngeal nerve, the RLN, differ both anatomically and clinically? Here's the breakdown. The ESLN is at risk high up in the neck, specifically when the surgeon is ligating the superior thyroid artery. If you injure it, it exclusively paralyzes the cricothyroid muscle. Practically speaking, the patient loses the ability to tense their vocal cords, they lose their high-pitched tones, and get severe vocal fatigue, which is obviously devastating if they're a singer or a public speaker. On the flip side, the RLN is at risk lower down, particularly during the dissection of the ligament of Berry. A unilateral RLN injury paralyzes all the other intrinsic larynx muscles. The vocal cord basically gets stuck in a paramedian fixed position. The healthy cord tries its best to close the gap, but can't quite meet it, which leaves the patient with a weak, hoarse, and breathy voice. Moving straight into question 10. After a completion thyroidectomy for advanced papillary thyroid cancer, the patient is going to need adjuvant radioactive iodine-131 ablation therapy. We have to wipe out any microscopic residual disease. But to optimize the uptake of this radioactive iodine by whatever cells are left, what exact physiological state do we have to actively induce before we give the therapy? The answer is B, an elevated TSH greater than 30 milliunits per liter. Here's why. Thyroid cells naturally capture iodine using something called the sodium iodide symporter, and that symporter is heavily driven by thyroid-stimulating hormone, or TSH. So, by intentionally making the patient hypothyroid, either by stopping their levothyroxine or giving them an injection of recombinant human TSH, we force those remaining microscopic cancer cells to aggressively pull in that toxic radioactive iodine, effectively destroying them from the inside out. Let's pivot to parathyroid pathology with question 11. A 45-year-old female comes in with the classic presentation: stones, bones, abdominal groans, and psychiatric moans. She's got kidney stones, bone pain, a high serum calcium of 11.8, and an inappropriately high intact PTH of 120. So, looking at the options, diffuse hyperplasia, a single adenoma, carcinoma, or ectopic PTH, what is the single most common underlying cause of primary hyperparathyroidism? Answer B. Now, what's really interesting here is just how statistically dominant a single benign parathyroid adenoma is. It is the absolute culprit behind primary hyperparathyroidism in approximately 85% of all cases. To put that in perspective, 4-gland hyperplasia makes up about 15%, and parathyroid carcinomas are exceedingly rare, like well under 1%. Question 12. How exactly do we localize a parathyroid adenoma before heading into surgery? We run a very specific 2-step imaging protocol. Step 1 is a technetium-99m sestamibi scan. The radiotracer actually concentrates right in the hyperfunctional mitochondria of the adenoma. Step 2 is a high-resolution neck ultrasound. When you combine these two modalities, you get a localization accuracy of greater than 90%. That's what allows surgeons to perform a focused, minimally invasive parathyroidectomy on just one side of the neck. Question 13 hits on a crucial number. How do you confirm you've successfully taken out the adenoma while still in the OR? You check the intraoperative PTH. Intact parathyroid hormone has a super short half-life, literally just 3 to 5 minutes. So, according to the Miami criteria, your intraoperative PTH must drop by more than 50% from its highest pre-incision baseline at exactly 10 minutes post-excision. If it doesn't hit that 50% drop, you're either looking at a second adenoma or some unrecognized hyperplasia, and that operation has to continue. Let's break down our final case, question 14. We have a 50-year-old male with end-stage renal disease on dialysis. He's suffering from bone pain and calciphylaxis. His phosphorus is elevated at 7.5 simply because his failing kidneys can't excrete it. Meanwhile, his calcium is low at 8.2 because those same kidneys can't synthesize active vitamin D. So in desperate response to this chronic low calcium and high phosphorus, his intact PTH shoots way up, massively elevated at 900. This right here is the textbook definition of secondary hyperparathyroidism. It's a reactive, diffuse hyperplasia of all 4 glands trying everything they can to regulate homeostasis in a totally failing system. Precision in the endocrine neck requires mastering the microscopic, the anatomical, and the biochemical. That really sums it up, doesn't it? So I want to leave you with a thought. How is understanding the subtle differences, like a Samoma body versus a RET mutation, or the crucial surgical implications of the ESLN versus the RLN, going to change your clinical approach the next time you step into the operating room?